At Progressive Longevity Clinic, our role is not to diagnose or treat dementia itself. That remains the domain of neurology, geriatrics, psychiatry, and general practice. Our role sits earlier, identifying modifiable risk long before symptoms appear and supporting intervention while the brain remains resilient. As sport and exercise physicians, we sit at the intersection of metabolism, vascular health, physical function, and behaviour. And these are domains that are increasingly central to dementia risk. The aim today is to reframe dementia not as a late event, but as a long, cumulative, and partially modifiable biological process. If we understand where it begins and what drives it, we can meaningfully reduce risk decades before clinical presentation. Dementia does not begin with memory loss. For most individuals, pathological processes begin in midlife or earlier, remaining clinically silent for decades. During this period, we see reductions in cerebral blood flow, impaired brain glucose metabolism, and a gradual accumulation of amyloid and tau protein pathology. By the time a patient meets the criteria for mild cognitive impairment, much of the biology is already established, and although the diagnosis feels sudden, the disease process isn't. The timing mismatch explains why dementia is often diagnosed late and why late intervention has a limited impact. So prevention has to happen decades earlier. This model helps explain why dementia has been so difficult to treat once symptoms emerge. Amyloid accumulation, which typically occurs first, abnormal proteins like tau follow on, and then only later do we see neurodegeneration and measurable decline in cognition. And the symptoms then sit at the end of that trajectory. So most disease-modifying trials have targeted these later stages once neuronal loss has already been substantial. So it's not a failure of the therapeutic intent, it's a problem of timing. And from a prevention perspective, the actionable window is long before this preclinical phase when physiology is adaptable and lifestyle, metabolic, and vascular intervention can plausibly shift that trajectory. Genetics clearly influences dementia risk, but they're not deterministic. ApoE genotypes shift the probability without certainty. So even ApoE4 monozygotes have a 15 times increased risk approximately, but the outcomes vary. What explains that variation is not the gene alone, it's the interaction with metabolic health, vascular integrity, physical activity, sleep, head trauma history, education, and sex. Clinically, ApoE should be viewed as a risk amplifier, not a diagnosis. And when used appropriately, it can help identify individuals for whom earlier intervention is important. This slide highlights one of the strongest population-level associations in dementia prevention. Across large cohort studies, higher muscular strength, often measured by grip strength, is associated with substantially lower dementia risk. This dose-response relationship is continuous, with no clear upper threshold. Benefits are not confined to elite fitness, and they persist after adjustments for age, sex, cardiometabolic disease, smoking, and other factors. And this suggests that strength isn't merely a proxy for health, but it's an independent protective signal. Resistance training and physical capacity are therefore core components of brain health across the lifespan. Now, this study extends the protective role of movement. What we see here is moderate to vigorous physical activity at any dose reduces dementia risk across all levels of baseline frailty. And importantly, the benefits observed even at relatively modest volume. Clinically, this removes a common barrier. Exercise remains protective even later in life and in less robust individuals. So taken together with strength data, the message is clear. Both movement and physical capacity and strength modify dementia risk in an actionable way. This slide addresses a central disappointment in Alzheimer's therapeutics. Now, despite us coming up with things that can remove these plaques, this is a reduction in amyloid plaques using things like monoclonal antibodies and newer techniques like focused ultrasound, cognitive outcomes in the research have been modest. And this suggests that amyloid accumulation in neurons alone is insufficient to explain the neuronal failure. An alternative and increasingly supported framework emphasizes vascular dysfunction and insulin resistance, Reduced blood flow to the brain, impaired glucose delivery, create an energy crisis in neurons, and among the most metabolically demanding cells in the body these are. So with these pathological findings, researchers like Suzanne Delamonte and colleagues have even informally referred to Alzheimer's as type 3 diabetes. Amyloid may still matter, but it appears to be a marker of vulnerability rather than a primary driver, and the distinction helps explain why late-stage plaque removal has limited clinical impact. The other type of study that's very interesting are these FDG PET studies that consistently have demonstrated reduced cerebral glucose metabolism years and often decades before cognitive decline. Early changes occur in hippocampal and parietal regions and may precede amyloid accumulation. Longitudinal work by Mosconi and others shows hypometabolism predicts future decline even if cognitively these individuals are normal. And from a prevention standpoint, it's critical. Metabolic dysfunction precedes symptoms, reinforcing metabolic health as a legitimate early intervention target. Alzheimer's can be viewed as an energy failure syndrome. This slide integrates the vascular and metabolic models. Reduced blood flow and perfusion limits substrate and energy delivery, and insulin resistance impairs neuronal glucose uptake. The neuron then enters a state of chronic energy stress, triggering inflammation, synaptic dysfunction, and structural loss. It's no longer communicating normally. Interestingly, in research, ketone uptake seems to be relatively preserved, prompting ongoing research into other fuel strategies. But clinical evidence here remains evolving and needs to be interpreted cautiously. The key message here is not dietary prescription, it's just a principle. Neuronal health is inseparable from vascular and metabolic health. Vascular aging tracks closely with cognitive decline. As arteries stiffen and luminal diameters narrow, cerebral perfusion falls. And the brain is greedy for blood flow and oxygen. It accounts only for 2% of our body weight, but takes up to 20% of resting oxygen consumption. So it's highly sensitive to even modest reductions in blood flow. Markers such as carotid intermedia thickness, a proxy for plaque formation in these major arteries that supply the brain, show near linear associations with later cognitive decline, independent of classical Alzheimer's pathology. And this is why we routinely measure this on site. This reframes dementia partly as a vascular disease, making blood pressure control, lipid management, endothelial health, and physical activity central to prevention. This slide explains why individuals with similar pathology can present very differently. Cognitive reserve, shaped by education, language, music, complex motor skills, and lifelong cognitive engagement, allows some individuals to tolerate greater pathology before their symptoms emerge. That reserve tends to delay symptoms, but of course it doesn't eliminate risk, and the pathology continues beneath the surface. Clinically, this matters because apparent resilience can mask disease progression. So prevention has to still address the metabolic and vascular drivers, not just rely on cognitive stimulation and reserve. Now, baseline dementia risk reflects both non-modifiable and partially modifiable factors. On the non-modifiable factors, we've got age at the top, and that's number one. Sex does also modify risk. Family history and ApoE genotype shift the probability, and cognitive reserve does influence timing, but not the pathology. This framework helps us define a starting point. What matters next is how risk evolves over time, and that's where all of these modifiable factors on the left become more powerful, with an estimated 40% contribution to the development of dementia. Dementia arises rarely from a single pathway. Metabolic dysfunction alters glucose delivery and utilization. Vascular disease impairs perfusion. Chronic inflammation, sleep disruption, inactivity, alcohol exposure, and untreated hearing loss can all further contribute to and amplify risk. Psychological health also matters. Chronic stress and depression influence neuroinflammation, hippocampal volume, and behavioral capacity. So together, these interacting systems explain why dementia risk is dynamic and modifiable across decades. As risk accumulates silently, detection becomes challenging. Technically, Alzheimer's and most other neurodegenerative brain disorders are only truly diagnosed definitively at autopsy, Really, there's no single definitive test for brain disorders in living humans, so multimodal assessment remains essential. Formal neurocognitive testing detects subtle executive and processing changes. Olfactory testing reflects hippocampal involvement. Gait and motor variability increasingly correlate well with early neurodegeneration. Biomarkers and imaging can add context in selected individuals. The value of early detection is time. It allows intervention while the brain is still adaptable, and the decline is therefore not inevitable. Intervention evidence consistently supports a hierarchy approach to dementia detection and management. Exercise, even in established dementia, sits at the foundation. Both aerobic capacity and strength improve brain perfusion, insulin sensitivity, vascular function, and neurotrophic signaling for neuronal maintenance. Layered on top of this is metabolic control and sleep optimization and nutritional patterns. Mediterranean-style diets seem to show the most consistent protective associations in the available research, and cognitive and social engagement is important in building reserve. Adjuncts like hearing correction and hormonal therapy can be appropriate in selected cases, but across all layers, exercise and metabolic health remains at the foundation. And this is a structured prevention framework. This framework integrates risk identification, biology, detection, and intervention. First, we want to identify who's at high risk to adjust timing. Second, we want to target modifiable physiology rather than late pathology. Third, monitor for early change to guide the intensity of intervention. And finally, intervene where the evidence is strongest. This approach doesn't guarantee prevention of neurodegenerative disease, but it offers a structured way to meaningfully reduce risk over time. Thank you for your attention and engagement. Dementia is a complex multifactorial condition with no single discipline owning its prevention. As sport and exercise physicians, our contribution sits upstream. We work alongside GPs, neurologists, geriatricians, psychiatrists, and allied health professionals to support risk reduction at a stage where biology remains adaptable. The information presented today is intended for general education and professional discussion only. It does not constitute individual medical advice, doesn't replace consultation with a treating clinician, and does not establish a doctor-patient relationship. Decisions regarding assessment, screening, and management should always be made in the context of individual clinical circumstances and in collaboration with appropriate specialists.